So the disease is called neuromyelitis optica. Like I said, it used to be called Devick's disease. Dr. Devick in the late 1800s discovered the disease, published the first 16 cases together, and recommended the name neuromyelitis optica, but nobody took his suggestion and they just called it Devick's disease. But like I said, since 2005, there was a biomarker that was discovered for this disease, and that has really revolutionized the field and made a lot of people interested, even Vijay Kutru, interested in this disease. So my outline is basically to introduce you to this disease, talk about two models for how we think about it. One is a pathogenic antibody model, and the other is the role of Th17s. So clinically, the way we think about neuromyelitis optica is by localization. So MS classically involves the entire brain, optic nerves and spinal cord. Transverse myelitis, by definition, involves just the spinal cord. But neuromyelitis optica is one of those unique diseases that localization-wise involves spinal cord and optic nerves. And that's kind of usually the only thing medical students learn about this disease, so it's really the most classic feature about it. Another way to think about neuromyelitis optica is by clinical recurrence rate. Neuromyelitis optica, if it's untreated, can relapse 3 or 4 times a year. It's a very aggressive and severe disease. MS can do that too, but it has a broader spectrum. And then another way to think about neuromyelitis optica is on the pathology spectrum. So it tends to look very humoral on pathology. In 2002, the Mayo Clinic's Dr. Licanetti described a case series of NMO patient pathology. And what you can see are lots of complement deposition in 2 patterns. One is a rosette pattern and one is a rim pattern. She found a lot of immunoglobulin deposition around blood vessels, IgG and IgM. This is a blow-up of complement, and then lots of macrophages. You can also see neutrophils. You have to trust me, these are sort of 2 or 3 lobe nuclei here. And importantly with this disease, you see areas in the lesion that are devoid of a water channel called aquaporin 4. So in brown is the staining for aquaporin 4, and here is a lesion that doesn't have aquaporin 4. And aquaporin 4 is really important in this disease because the NMO-IgG is the biomarker that was discovered in 2005. And it's basically an IgG1 antibody. It's highly, highly specific for NMO. So if you have one case of optic neuritis or transverse myelitis and you test positive for this antibody, there's probably a 99% chance or greater that you're going to have a relapse of optic neuritis or transverse myelitis and develop full-blown NMO. So very, very specific. The problem is the sensitivity has been in the 50s to 70%, so you test and retest. That's been improving over time, and now it's to the point that there's a cell-based assay that picks up about 80% of these patients, and the thinking is that as we improve these assays, there won't be any seronegative patients. Everyone will have this antibody. It's that good of a biomarker. And in 2005, the Mayo group figured out that this antibody biomarker found in these patients binds to aquaporin 4. So aquaporin 4 is the predominant water channel in the brain. There's different aquaporins in choroid plexus and ependyma, but in the parenchyma of the brain, it's all aquaporin 4. That's true in the spinal cord and optic nerve as well. Aquaporin 4 is sort of polarized along astrocytes, so there's a lot of aquaporin 4 around blood vessels, on the abluminal surface, so on the outside of blood vessels. And then the other side sort of grips the synapse, and so it helps shuttle water and potassium back and forth between the synapse and the blood. One of the neat things about aquaporin 4 is if you look at freeze fracture electron microscopy, and here's a blow-up, is that aquaporin 4 forms these really pretty rectangular arrays, and they're perfectly spaced out. And so the thinking early on is that you have this antibody in patients, and if it sticks to these arrays, it's spaced apart so perfectly that it would easily fix complement and could explain a lot of the pathology you see in human patients. So this pathogenic antibody model really took hold in 2007, 2008. And so we jumped on that idea and talked to Dr. Jackman sitting here in the audience, and I said, if this is a real pathogenic antibody, how do we prove it? And he said, he actually gave me 5 criteria, but I'm going to list 3 here for you that we actually have worked on. One is, first of all, you have to prove that the NMO antibody has to actually bind its target. It would be nice to show that if you passively transfer this antibody from a human patient to an animal model, that you could reproduce features of the disease. And if you can raise antibodies against aquaporin 4 and sort of make synthetic NMO antibodies, that should also recreate some features of disease. So to prove the first point, that NMO-IgG binds aquaporin 4, that's pretty well established already. Again, the Mayo group showed that aquaporin 4 here in green, expressed on cells, will bind the NMO-IgG from patients. It's an extracellular epitope. So if you take commercially available anti-aquaporin 4 on live cells, it won't stick because it has an intracellular epitope. But with NMO patients, if you add it, there's a red signal here. I'm not sure if you could see it in the back. It actually binds very well to the extracellular membranes of these cells expressing aquaporin 4. In tissue, the antibody binds aquaporin 4 here on blood vessels. Here's a blow-up of blood vessels in the brain. Virchow-Robin spaces in the brain have expressed aquaporin 4, and the antibody binds there. And then on the pia glia limitans, where aquaporin 4 is also highly enriched, you get binding from patient blood. What about in vivo? In vivo, you actually have to inject it into the brain. So this is an injection of human antibody plus complement, and you can recreate features of the disease. There's lots of inflammation. This is the control. There are neutrophils, macrophages, and then those patterns of complement deposition. So again, recreating features of the disease just from having the antibody present and bind to aquaporin 4. Now, in patients, the antibody is not really found in the spinal fluid. It's only rarely found in the spinal fluid. It's mostly found in the blood. It's produced peripherally. So in order for this model to be true, the aquaporin 4 antibody has to actually reach its target, aquaporin 4, in the brain. So to address this issue, one thing I should mention is that aquaporin 4 is found throughout the body. It's highly enriched in the lung. You find plenty in the stomach and in the kidney. The central nervous system is the second highest expressor of aquaporin 4. And if you consider where in the central nervous system aquaporin 4 is mostly expressed, spinal cord and optic nerve are the highest, followed by brainstem, and then brain and cerebellum. And if you consider what parts of the central nervous system are most affected in the disease, it's spinal cord and optic nerve, a little bit of brainstem, and then rarely brain and hardly ever cerebellum. So if the antibody is pathogenic and it just has to reach its target, then this would fit with the model that the areas that have the most aquaporin 4 would be the most targeted by a pathogenic antibody. So we took the human IgG fraction from patients, injected it into the blood of mice, and it did nothing. And several people have reproduced this. You could even give them lipopolysaccharides, LPS, to get the antibody in. It still doesn't do anything. It's not pathogenic alone. But if you use the model that EAE as Vijay introduced, experimental autoimmune encephalomyelitis, in that background, if you add the antibody does get into the central nervous system. This is a cut of the spinal cord here, and the antibody binds areas enriched in aquaporin 4 along the pia. This is a control antibody from a patient who doesn't have NMO. In EAE, the antibodies still get into the meninges, but they don't get into the parenchyma of spinal cord. There's nothing for them to bind to there. So I think I've at least convinced myself that the number one criteria is true, that the NMO antibody does bind aquaporin 4. It binds it in animal models as well. What about passive transfer? So in these mice, in the background of EAE that got the antibody, this is an EAE score, as Vijay introduced. The higher, the worse. So with a score of 1, the mouse may have a limp tail. Score of 2, you start to get weakness in the hind limbs. And the higher up you go, the higher the paralysis goes. In normal EAE, about 10 days after immunizing with a myelin peptide, mice will get sick. They'll have limp tails. They'll start limping with their hind legs. And this is what a control animal usually looks like. If you add the antibody at these 4 time points, you can exacerbate the disease, and they stay worse over time. If you take IgG from patients that don't have NMO, you also see an initial worsening, but then they come back to about the same level as controls. And I think I understand a little bit why taking a patient who doesn't have NMO and giving the antibody to the mouse makes them a little sick. And I think it has to do, the same pathology has to do with why NMO gets worse with their antibody. And that has to do with neutrophil recruitment. So in green here, in green are the neutrophils. And what you see in the group that got NMO-IgG, you see lots of perivascular neutrophils. These are not typical in EAE. So in typical EAE, if you could see here in red, you just get T-cell inflammation in the spinal cord. But with the passive transfer of the NMO-IgG, you recruit neutrophils here. And these cause a lot more damage. I should also mention in the group that got the IgG not from an NMO patient, there was still some neutrophils around, and there's still a little bit more damage, but not quite the same perivascular inflammation that we see with the NMO-IgG group. And when you look at the myelin damage as a result of all these neutrophils, this is pretty typical EAE. You get these dorsal column demyelinated lesions. Blue is myelin, and lack of blue is loss of myelin. In the NMO-IgG group, you get these large peel lesions. You can see here a blow up. That whole area is demyelinated. When we quantify this, we see a lot more of these big peel lesions with the NMO antibody. And we think that's due to neutrophil infiltration. Optic nerves are harder to quantify, but you still see a little bit here of the demyelination in the optic nerve in the NMO-IgG group as compared to the control groups that have smaller lesions, although it is harder to quantify an optic nerve. So passive transfer of the antibody does make the disease worse. It does recreate some of the phenotype, but it needs a background of EAE. It doesn't just happen with passive transfer alone. And I'll get to why I think that is. The third component is trying to create an antibody against aquaporin-4 and recreate some of the features of the disease. Mice don't tend to do that. They don't, C57 black 6 mice don't overcome tolerance very easily, and we tried many times to create aquaporin-4 antibodies in mice. It doesn't work. But in rats, Lewis rats, they tend to make plenty of antibody. We can create high titers against extracellular epitopes of aquaporin-4, and when we do that, the rats don't get sick. So they have lots of antibody against aquaporin-4 circulating around, and they don't get sick. Again, what if we need an EAE background? So we tested that. So these rats got EAE, plus they made antibody against aquaporin-4 against an extracellular epitope, and they're really no different. So it doesn't appear that creating antibody against aquaporin-4 is the same as taking the human antibody and passively transferring it. And that may have to do with how the antibody sticks to those arrays I showed you of aquaporin-4. It's thought that the human antibody actually binds to that three-dimensional conformation, and just creating an extracellular epitope doesn't recreate that three-dimensional binding. So kind of a question mark here. We may need to just create a better antibody. And when we consider T cells in NMO, there are a couple of good arguments for involvement of T cells. The first is that the NMO-IgG is an IgG1, or few IgG4s, but mostly IgG1, which requires T cells for that switching. The pathogenic antibody models I just showed you, they all depend on EAE, or some sort of T cell background, activated T cell background. And then thirdly, you do see some T cells in NMO pathology. So these are pretty good arguments for why T cells are involved. So what we did in trying to make the antibody is we found that C57 black 6 mice, if you knock out aquaporin-4 and then immunize them with pieces of aquaporin-4, there's one epitope in particular that these T cells tend to react to, and that's the second extracellular loop of aquaporin-4. So we could take these T cells that are reactive against aquaporin-4 from knockout mice and then transplant them into wild-type mice and see if they're pathogenic or if they attack aquaporin-4 in the wild-type mice. And they really didn't. I presented this at a meeting. I think VJ was there and a few other folks who said, well, if those T cells, if you polarize them towards a Th17 phenotype, try that, see what happens. I bet that would be pathogenic. And so we did just that, and they truly were. So you could adoptively transfer those Th17 polarized T cells that are reactive against aquaporin-4, and you start to see weakness, limping. And for the first time in my life, I saw a mouse blink. I didn't know that mice could blink. I didn't know they had eyelids, but they really do, and they have irritated optic neuritis, irritable optic neuritis. Here's a little bit of the pathology. It's hard to see or at least it's hard for me to see from this point of view, but this is a cut of the spinal cord and axial section where there's tons of these blue cells. This is DAPI stain for inflammatory cells. When we look at them, they're IL-17 T cells and neutrophils, and they're just coating all the meninges. They infiltrate the P a little bit. In this section, which you can't see very well, there's a blood vessel here with lots of inflammatory cells and causing a lot of destruction. Here's an optic nerve, one of the mice that actually got a necrotic eye. The optic nerve itself is damaged. There are inflammatory cells here, including neutrophils, and there's also loss of myelin in these areas. So in summary, it does appear that NMO-IgG has some effect on the pathology of the disease. It may be a pathogenic antibody, but it certainly needs another component of the immune system to affect that pathology. NMO is unique in that it actually has an antibody and an antigen. It's one of the few neurologic diseases where you could actually put your finger on something and say, this is the problem and this is how we can potentially fix it. And then Th17 cells may play a role. There's some discussion about using therapies against Th17s, like the drugs used for psoriasis to test them in NMO. So rather than showing all the people who were involved in this lab work, I'm going to show the people who kept me from doing my lab work, my girls, and I'll take any questions.
Okay, I know that aquaporin 4, they've been implicated in some multiple sclerosis, so I was wondering if you see any MS patients with that antibody. I mean, is there anything like that?
The consensus now is if you see the antibody against aquaporin 4 in MS, then they don't have MS.
Okay.
Then it is NMO, almost exclusively.
Okay.
There's also pathology in MS that does involve aquaporin 4. You do see a loss in acute lesions, and then it comes back over time. In NMO, the aquaporin 4 stays gone.
Okay.
So there's some involvement of aquaporin 4 in MS, but the antibody itself against aquaporin 4, it's definitely not MS.
Okay. Thanks.
Does IgG4 by itself ameliorate disease? That's the one with that does the arm exchange and non-inflammatory.
Yeah, not clear. You know, there are a lot of people who use IVIG, which is an amalgamation of all the IgGs, to treat NMO and has some variable effects. But nobody's really looked at the different types of IgG, whether some are pathogenic, some are not. Yeah. It might project. Please, Barbara.
So you definitely showed, humoral and cellular component in pathogenicity of this disease, but to get closer to hypothesis about pathogenicity of this particular antibody would be to look for the presence of C4D in the lesions, because C4D is early component of complement activation and really associated with activation of complement by antibodies.
Would you see that in the human pathology as well?
In human and mouse. Because this is at the early level of complement activation, because you really don't know whether this pathogenicity of these antibodies are associated with specific recognition of the target,
right,
or binding of this antibody to FC receptors. Because this antibody is mainly IgG1, which is not highly complement activating subclass, in humans, IgG3 is really complement activating. So I would suggest to look for.
Is that C4D? I mean, does it quickly disappear? Because
no,
the argument that's been made for looking at C9neo is that it hangs around forever.
This is the beauty of C4D, because C4D is covalently bound to the target, and once C4b is produced, then it produces final complement, final product, which is C4d, and covalently bound to the target, and it's very easy, to detect.
I'm going to bring some tissue by your lab today.
We have to talk. We have to talk. Okay.
I was curious about the distribution of aquaporin 4, because do you also see isolated spinal cord lesions in this disease, or does it have to, by definition, include optic nerve lesions?
Clinically, you have to have optic neuritis to have the diagnosis, but if someone has transverse myelitis with the antibody, then we don't wait for them to develop optic neuritis. We'll treat them.
Yeah. Okay.
One of the interesting things about this disease is that everyone presumes that the target antigen is aquaporin 4 because there's an antibody against it in the blood. There's aquaporin 4 throughout the body, and these patients don't get lung disease, heart disease, kidney disease, or anything else. The other interesting thing is that when we took these aquaporin 4 specific T cells and polarized them towards the Th17 phenotype, they just went for the brain. We looked at the kidney, we looked at the lung, we looked at every other aquaporin 4 expressing organ, and there was no inflammation there. So, is VJ still? Do you have any thoughts about why a Th17 T cell directed against aquaporin 4 would just go to the brain? Does it have anything? Is it really aquaporin 4 specific, or is it more just Th17 specific that it would go to the central nervous system rather than?
Th17 cells don't go anywhere near antigen specificity.
Okay, so it is antigen specific. It has to be.
Cells. I mean, this has been an ongoing debate as to why they should target the brain, optic nerve and spinal cord, and not go anywhere else.
Right.
And same thing is true for myelin basic protein. Myelin basic protein, specific T cells always induce EAE. They don't induce peripheral neuritis.
Right.
When you have myelin basic protein in both peripheral nerves and in central nervous system. And in that case, it's those particular epitopes that are being produced in very large quantities in those places, especially brain and spinal cord. So it may be something very similar. It will be very good to do is have an antibody against the MHC and the peptide, and then go fishing as to why these epitopes are linked to MHC in different places.
Dr. Jackman. That's a great question. The Mayo did a trial of Eculizumab, C5 inhibitor. And the data they showed in 14 patients who failed everything else was complete remission. The only problem is one of their 14 developed Neisseria meningitis, which is a problem with these complement inhibitors. So I don't know if it will become clinically available, but as proof of principle, inhibiting complement works very well. And it is the most expensive drug in the country, yeah. Second problem with it. Please, in the back.
Is there any effect on the ganglion cells in the retina?
I don't know the answer to that. I know that there's aquaporin 4 expressing cells in the retina that are thought to be affected in NMO. If you look by OCT, you see those cystic changes I told you about at dinner. But I don't know that that there's true inflammation there and that there's any retinitis or anything else going on.
I was just wondering what the standard treatment was and what the mechanism of action of the drugs were.
The treatment may not explain a lot of the disease. One of the treatments is an anti-CD20 antibody, so you deplete B cells, and these patients tend to do very well. Another approach is just immunosuppression with a drug like mycophenolate or any other transplant drug. Any immunosuppression tactic will work, including steroids. Okay. Thank you.
I really wish you didn't start with the phrase, "You won't regret staying." I always feel like that puts an undue burden on me. Because sitting in the audience this afternoon, I realize that unfortunately all of you are about to become the victims of symposium syndrome. So symposium syndrome is when you're invited to a conference, and after spending the afternoon seeing some very lovely and very elegant immunology and histopathology, all of a sudden some rude speaker comes up and throws you into clinical medicine. which unfortunately is not elegant and not neat. And I wish I could say otherwise, but I feel obligated to apologize for that right off the bat. The second thing I wanted to note is that normally when I'm talking, I'm preaching to the converted. Most of the times when I speak about vasculitis, I'm talking to other rheumatologists. But I understand that this audience is quite a deal more diverse than my standard audience. So when I talk to a diverse group like this one, I only come with one goal in mind, which is I would like each one of you to leave here equally irritated with me. Because I know that for some of you, you're very familiar with the ANCA-associated vasculitides. But I know for some of you, you don't know what ANCA is, you don't really know what vasculitis is, you're not really sure what a rheumatologist is, and quite frankly, you're not sure why I'm actually standing here this afternoon. So keeping that in mind, what I'd like to do today is I'd like to go over some of the basics. I'd like to start with talking a little bit about what vasculitis is, what it is I really do for a living, the different diseases that are classified under the rubric of vasculitis, and then we'll talk a little bit more specifically about the ANCA-associated vasculitides, in particular the way that ANCA-associated vasculitis is treated, and the way that the treatment of ANCA-associated vasculitis has evolved over just the last couple of years. So first, let's talk about some basic facts. The first thing to know is that vasculitis affects people of all ages, although it tends to affect people in midlife, which is a period that as I get older, I mark as older and older. So maybe let's say 40s and 50s, but it certainly can affect people as young as 2 or 3 years old. Vasculitis tends to be a disease of Caucasians, which always comes as a surprise to my African American patients, of whom there are legion in my clinic, being in Baltimore, Maryland. Vasculitis does have a genetic component, but it's not inherited in the same way that eye color and hair color are inherited. So even though there is a genetic component, clearly that's only one very small piece of the puzzle. Finally, for the majority of patients I see, vasculitis is a chronic relapsing disease. So while it's true that some patients with vasculitis have a monophasic illness where they only have it once and it goes away on its own, for the vast majority of patients, they'll be dealing with the complications of vasculitis for the rest of their lives. I'm not sure if you're familiar with this phenomenon where you can say something and your wife can say something and you're using exactly the same words, but you mean completely different things. That also applies to the word vasculitis, and it's actually one of the confusing things about my field, because depending on who's using the word vasculitis, you might mean very different things. So when a pathologist or a dermatologist uses the word vasculitis, they're literally saying that I see inflammation on a histopathology slide. But that's all they're saying. They're not making any other conclusions about what the diagnosis is, what the underlying problem is for the patient. They're just saying that this is what I see. Now, when a rheumatologist or a nephrologist uses the word vasculitis, we're talking about syndromes that are characterized by the presence of blood vessel inflammation, but that's only one small part of a much larger problem. There are about 20 commonly recognized forms of vasculitis, and this is a list of the highlights. And back in the days of the giants, so Mary Betty Stevens, who comes way back in the history of rheumatology at Johns Hopkins, these patients were classified in terms of histopathologic characteristics. So we talked about immune complex-mediated vasculitis, granulomatous vasculitis, and so on. And at some point, we realized that patients didn't like it when we biopsied their brain or their aorta or other parts of their bodies that they actually kind of preferred intact. So it turned out that histopathology, although very neat and very nice, ended up not being a very practical way to approach these patients when you're taking care of them clinically. Because the original criteria, of course, were based on autopsy studies. So again, not practical for a doctor like me. So the classification system was rearranged in 1994 to be clinical. So instead of talking about histopathologic characteristics, we now talk about patients in terms of the size of the blood vessel that seems to be involved. So we now think about patients in terms of large vessel vasculitis, medium vessel vasculitis, and small vessel vasculitis. So what does that mean? So large vessel vasculitis refers to vasculitis that affects the aorta and what we used to call the great vessels. So that means the carotid arteries that provide circulation to your head and the subclavian arteries that provide circulation to your arms. And that's pretty much it. Medium vessel vasculitis refers to vasculitis that affects the arteries that have a muscular wall. So those of you who went through an anatomy final at some point realize that those are the arteries that are large enough to have an anatomic name. So the radial artery, the ulnar artery, the superior mesenteric artery, the inferior mesenteric artery, any artery that's large enough to be anatomically defined probably has a muscular wall. The small vessels are pretty much everything else. So the capillaries, the arterioles, and the venules that supply blood to the organs. And the reason why this classification system is so brilliant is that once you know what general class of vasculitis your patient has, you can actually predict almost all of the clinical characteristics. So let's talk about large vessel vasculitis. So when you think about a patient with large vessel vasculitis and they're having problem getting blood down that arm will get tired and painful after they're doing something 2, 3, 4 times in a row. And that type of pain is called claudication. That's very classic for large vessel vasculitis. When you think about someone who has carotid involvement, that person might have blindness or stroke because of loss of circulation to their brain. When you think about a medium vessel vasculitis, a patient might develop something called mononeuritis multiplex because of loss of circulation to the major nerves in the arms and legs. And the way that presents is someone's unable to lift up their wrist or someone's unable to lift up their foot when they walk. Another manifestation is mesenteric angina, and that's the pain that someone develops maybe an hour after they eat, not because they ate too much, but because the blood just can't make it down fast enough to their gut in order to help them digest food. Finally, if the medium vessel that's involved is one of the vessels that's supplying the skin, when that ischemia takes place, they actually lose large segments of skin, and it forms these very large, very painful ulcerations that are quite distinctive. Now, small vessel vasculitis typically causes 3 different problems. It can go up to the skin, where it causes these little tiny purple dots called palpable purpura. If it affects the kidneys, it causes kidney inflammation called glomerulonephritis. And it affects the lungs, it develops into pulmonary capillaritis, and these patients present coughing up blood because of pulmonary hemorrhage. Now, it's this last category in which ANCA-associated vasculitis belongs. And the reason why we separate these patients out is because all these patients are characterized by the presence of an anti-neutrophil cytoplasmic antibody. And that ends up being these 3 diagnoses. And this is the official definition. And just like every single official definition, it's not so helpful, right? So instead of sticking to that, what I want to do is I want to talk to you a little bit about the way that I think about these diseases, knowing that with any simplification, there are going to be 1 or 2 patients you're going to see that are going to break the rules. But when I think about these diseases, I think about them as belonging to a large family. And microscopic polyangiitis is the most simple of the family because this is the disease that only involves blood vessel inflammation and nothing else. This is the diagnosis that the medical student can figure out based on an anatomy textbook and a general understanding of first principles, because all these patients have are blood vessel inflammation. It's these other diagnoses that get a little bit more complicated, because those other diagnoses are characterized by blood vessel inflammation plus something else that's going on that make these diagnoses unique. Now, in the case of the Churg-Strauss syndrome, that extra thing is hypereosinophilia, and the very characteristic manifestations of this diagnosis are driven by the presence of eosinophils. So when they go into the heart, they cause cardiac dysfunction, or called myocarditis. When it goes into the lungs, it creates these fleeting pulmonary infiltrates, which are part of a classic description of Churg-Strauss. And when it goes into the lungs, it also causes bronchospasm that can be so severe it can only be controlled by steroids. Now, with granulomatosis, with polyangiitis, which is the disease that we used to call Wegener's granulomatosis, that extra component, of course, is the presence of necrotizing granuloma, typically present in the respiratory system. So starting at the bottom, you think about people with large cavitary lesions that look just like lung cancer or tuberculosis. Moving up to the throat, they develop stenotic lesions in the airway called subglottic stenosis, which causes this raspy Darth Vader pattern to their voice when they talk. Moving upward to the sinuses, it creates this very bad chronic sinusitis, and typically these patients come in having treated with multiple courses of antibiotics, multiple allergy shots, and absolutely no relief. Finally, these patients can develop very large masses behind their eye that forces their eye forward, looking very similar to what patients look like when they have Graves' eye disease. So now that you know all this, you're prepared to answer the really important question of this afternoon, which is, why do you care? So I'm the first to acknowledge that these are not really, really common diagnoses, right? It's not like I'm talking to you about hypertension or diabetes. So the question always comes up is, why is this even worth thinking about? So these are the incidences associated with these diagnoses. And again, I admit that this is not the most common disease that you're going to see, but let me put these numbers in perspective for you. The odds of having a royal flush, 1 out of 0.6 million. The odds of being killed by lightning, 1 out of 2 million. The odds of winning the California state lottery, 1 out of 13 million. So if you've ever purchased a lottery ticket, if you've ever yelled at the kids to get out of the pool because it's starting to rain, or if you've ever waited for the river card to come down when you're playing poker with the boys, then you know as well as I do that rare events can and do occur all the time. I want to switch gears and talk a little bit about the treatment of ANCA-associated vasculitis. And I'm starting with this quote because it's just relevant to the next paper I'm going to present, which is this. So if you accept this as the definition of a classic, then this counts as a classic manuscript in my field, because this is easily the most cited, the least read paper in my field. Because every review article on ANCA-associated vasculitis starts with this paper, because it's the first large case series of patients who had this diagnosis. And the reason why I bring it up today is because even back then, they made a very relevant observation, which is that these are deadly diseases. So when they described a case series of patients who had granulomatosis with polyangiitis, Walton noted that the course is usually rapid and full of incident, progressing to death in on average 5 months, and occasionally in as little as 4 weeks. Now, Walton went on to say some things that he probably was less proud of. So, for example, he said the treatment of ANCA-associated vasculitis should be radiotherapy. That ends up not being true. But the primary observation that he made, that these are fatal diagnoses, did hold true. And in fact, without any treatment at all, we know that patients are basically going to die within that first year after diagnosis. We know that mortality in that first year is 82%, and we know that the mean survival time is only 5 months. And even with the advent of glucocorticoid therapy, which basically revolutionized autoimmune diseases in some ways, that number didn't really change all that much. So the average survival time went up from 5 months to 12.5 months, but steroids by themselves were not a cure. It was really the onset of cyclophosphamide, which of course is a cytotoxic agent that revolutionized the treatment of ANCA-associated vasculitis and changed these diagnoses from diseases that are associated with 100% mortality to diseases that are associated with cycles of relapse and remission. Now, these data go back to the old Fauci-Wolff protocol, which was designed by the NIH in the 1960s. And patients who are treated in this fashion often received 5 years or longer of cyclophosphamide therapy. And to understand why that's a problem, we have to talk a little bit about the mechanism of cyclophosphamide. So let's say that's vasculitis. That's cyclophosphamide. So cyclophosphamide, remember, is a derivative of nitrogen mustard gas, which in World War II was used in chemical warfare. This is not a gentle drug. We know full well that it's broadly immunosuppressive and B-cell and T-cell specific. But in addition to that, we know that it's an alkylating agent that causes widespread damage even when used at relatively low doses. So what does that really mean? So when treated with cyclophosphamide using the old NIH regimen, we know it's a very effective treatment for patients with ANCA-associated vasculitis. We know that virtually all patients will respond, and 3/4 of patients will go into remission. And if that's all I had to say about cyclophosphamide, we might not actually have a reason to talk this afternoon. But of course, that's only the tip of the iceberg. The problem with cyclophosphamide is that remission comes at a cost. I know when I treat with patients with cyclophosphamide, a substantial number of patients will develop some form of permanent morbidity. About half of those patients will become infertile. About half of those patients will develop a serious infection. There's an 11-fold increased risk of lymphoma and a 33-fold increased risk of bladder cancer. And that's to say nothing about the associated risk with the high doses of steroids that I routinely use to treat my patients with vasculitis. The real problems with cyclophosphamide come at the extremes of age. So I always think about young people who are worried about maintaining fertility. I always think about older people who may not be able to tolerate a cytotoxic agent. Remember also with cyclophosphamide, I pointed out before that 75% of patients will go into remission, but that means that 25% will not. That's 1 out of 4. That's not a great number. The other thing to remember is that some patients who are exposed to cyclophosphamide cannot tolerate it again, either because they developed hemorrhagic cystitis, bone marrow suppression, or some other complication that prevents you from using this drug. And as little as 3 or 4 years ago, we didn't really have an alternative for patients in that particular situation, but now we do. And this is the alternative. So this, of course, is Rituximab, which is a monoclonal antibody against CD20. And we don't exactly know how it works, but what we do know is that when patients are treated with monoclonal antibodies against CD20, they have very rapid depletion of B-cell levels, and that B-cell depletion will last for 4 months or longer. Now, the reason why people started looking at Rituximab to begin with ANCA-associated vasculitis was rather simplistic, because they thought that the disease was associated with these ANCA antibodies, and if we could find some way of getting rid of these ANCA antibodies, maybe the disease would go away. We now know that the story is a lot more complicated than that, because B cells truly serve many functions in patients who have ANCA-associated vasculitis. We know they're involved in antigen presentation, cytokine production, and in crosstalk with T cells. So there are lots of different ways where B cell depletion might affect patients with ANCA-associated vasculitis. All of this work led to the RAVE trial, which is called Rituximab and ANCA-associated vasculitis, which was published in the New England Journal of Medicine back in 2010. And what this study did was they took patients who had ANCA-associated vasculitis, and they treated them initially with glucocorticoids, but then randomized them to 2 different treatment strategies. Now, half the patients received what I would standardly use in my clinic. So they received 6 months of cyclophosphamide and then 12 months of azathioprine, which is a more mild form of immunosuppression. The other half receive rituximab, and when a patient receives rituximab, they get 1 injection once a week for 4 weeks, and then nothing else except for a prednisone taper for the rest of the study. So 197 patients were enrolled, and the majority of patients did make it to the primary endpoint, which occurred at 6 months. So what happened to the B cell counts? Well, you can see here that rituximab is an incredibly effective agent at depleting B cells. The B cells drop dramatically, and they stay suppressed for a very long period of time. So long, in fact, that based on the original case series, we thought that patients might actually become tolerant of ANCA at some point, although that ended up not being the case. The interesting message over here, though, is that cyclophosphamide is also very efficient at depleting B cells. And the reason why that's interesting is because before this trial took place, no one talked about B cells in ANCA-associated vasculitis, especially with GPA, granulomatosis with polyangiitis. We all said that this must be a T-cell-mediated disease because of the presence of granuloma. There's no reason to look at B cells. After this slide occurred, all of a sudden people kept on talking about what a wonderful B-cell agent cyclophosphamide actually was, and how, of course, it was intrinsic to the mechanism of cyclophosphamide when we were treating patients with ANCA-associated vasculitis. So it's interesting to see how, in retrospect, clinical trials can feed our understanding of the pathophysiology of disease. When you look at the effect of rituximab versus cyclophosphamide for remission induction in patients with ANCA-associated vasculitis, you can see that they're about the same. That patients who get treated with rituximab and patients who get treated with cyclophosphamide enter remission at exactly the same rate. Now I'm going to show you these data in a slightly different way just to show you how close we came to proving something just a little bit more interesting. So over here is the boundary that would have to be surpassed to demonstrate non-inferiority. This is the boundary that would have to be surpassed in order to demonstrate superiority. That number is 3.2%. You can see how close we came to surpassing that particular boundary. And you can imagine if the trial was just a little bit larger, if it had just a little bit of a different study design, that it might actually have proven that rituximab is even more effective than cyclophosphamide for the treatment of patients with ANCA-associated vasculitis. One of the criticisms of this particular study is that the majority of patients in this study had GPA, which is true. But the question was, could we really say that it's an effective agent also for MPA, which was also studied in this study? And the answer seems to be yes. So if you look just at the patients who had microscopic polyangiitis over here, you can see that it doesn't seem to make a difference whether they got rituximab or cyclophosphamide. They all seem to enter remission at about the same rate. And in fact, if you looked at the patients with granulomatosis with polyangiitis, you can see that rituximab seemed to be even just a little bit better at getting patients in remission than did cyclophosphamide, although this difference is not statistically significant. This difference is statistically significant, though, I think is an important observation. So this particular subgroup analysis divided up patients in terms of what their disease status was prior to the trial. So this group had no diagnosis of vasculitis prior to trial entry. These patients had brand new disease. These patients had a history of relapse before they entered the trial. So you can see if you came into the trial with a brand new diagnosis of vasculitis, it didn't really matter what you got. You did equally well if you got rituximab or cyclophosphamide. If you look at the patients with relapsing disease, though, you can see that patients did substantially better if they got treated with rituximab. Now, there are 2 possible explanations for that. The first explanation is maybe that the prior treatment with cyclophosphamide primes the pump, that maybe treatment with cyclophosphamide as a cytotoxic agent makes them even more amenable to the immunosuppressive effects of rituximab. The second possibility is that maybe it's not rocket science. Maybe what we did was we found a patient population that already failed cyclophosphamide once. Maybe it's not really that unusual to think that these patients would again fail cyclophosphamide if we used it again. Because I gave you a subgroup analysis, I wanted to show you this. This is ISIS-2. Those of you who went through medical school may remember this. This is one of the major trials that was done in cardiology many years ago that demonstrated that patients with heart attacks benefit from treatment with aspirin and lytics, which are agents like TPA and streptokinase. The ICIS study did 1 billion subgroup analyses in order to look for different ways in which they might be able to define which patients really benefited from this treatment. And one of the subgroup analyses they did was by astrological sign. So they separated people out in terms of an astrological sign of Gemini and Libra versus other birth signs. And what they found was, indeed, if you were born under the signs of Gemini or Libra under subgroup analysis, you did not benefit from aspirin and lytics if you had a heart attack. That's a long way of saying that subgroup analysis always has to be taken with a grain of salt. And yet, the reason why I show you this slide is because this actually reflects our clinical experience, that patients who have a history of relapsing disease seem to respond even better to rituximab than patients with new diagnoses. And this might be an important observation when we're trying to figure out which patients should be treated with this very expensive drug. This is a slide that demonstrates the adverse events associated with rituximab versus cyclophosphamide. And you can see here that it seems to indicate that cyclophosphamide is a little bit more dangerous than rituximab, and yet the numbers are skewed. Because if you look at the reason why the patients who receive cyclophosphamide seem to have more adverse events, it all comes down to the incidence of leukopenia, which frankly is of course going to happen in patients who get treated with a cytotoxic agent. So I don't think it's fair based on this slide to say that cyclophosphamide is more dangerous than rituximab for the treatment of patients with vasculitis. But the idea that's occurring to all of you is, why is it that the change didn't go the other way? Why can't I show that rituximab is actually a lot safer than cyclophosphamide? Because I just spent a lot of time telling you how dangerous cyclophosphamide is for patients, but this slide doesn't seem to show that, right? Because it seems to show that adverse events are about equal in both groups. And this is probably the reason why. This is the protocolized steroid taper that patients received in this study. And you can see that patients in the rituximab group and the cyclophosphamide group got treated with basically identical steroid tapers that started very high. So these patients received 60 to 80 milligrams of prednisone up front for that first month, and then received the same amount of prednisone for the next 6 months. So in these studies, it's probably the prednisone dose at the really high doses that we use to treat vasculitis that's driving all the adverse events. And there probably is a signal with rituximab, and it's just buried underneath all that steroid. All of you have realized that I've only been talking about the primary endpoint, which occurred at 6 months. 6 months is a sneeze, right? A patient could be in hospital for 6 months. The real question is what happens to these patients long term. So let me talk about that. So patients in this study were followed for a total of 18 months, and this shows the disposition of patients. So of the patients who started out on the trial, 61 patients in the rituximab arm and 63 patients in the cyclophosphamide arm managed to complete the study. And a good number of those patients actually remained in remission for the entire length of the study. So again, after being treated initially up front, 39 patients in the rituximab arm and 32 patients in the cyclophosphamide arm remained in remission for 18 months without any other interventions. But the question comes up as to what happened to those other patients. So when you think about severe disease flares, which means patients who had either pulmonary hemorrhage, glomerulonephritis, or some severe nerve involvement, you can see that flares occurred, but they occurred at equal rates regardless of what treatment they got. Now, if we think about relatively minor flares like arthritis or maybe some skin disease, which also occurs in patients with vasculitis, you can see these numbers go up, but they go up at an equal rate. So the number of flares that occur in the rituximab arm are equal to the number of flares that occur in the cyclophosphamide arm, even when you follow these patients out for 18 months. The other thing to notice is that the observation regarding adverse events doesn't change either. If you look at the adverse events in the rituximab versus cyclophosphamide arm, the number of events are identical no matter how you slice it. The last thing I'm going to say about this is that the duration of remission also is equivalent. So getting treated with rituximab up front manages to keep patients in remission for as long as being treated with cyclophosphamide up front. And the reason why that's remarkable is you've got to remember what the study design is. Remember the patients who got treated with rituximab got 1 injection once a week for 4 weeks and then nothing else for 18 months. And that's just as effective as the 6 months of cyclophosphamide and the 12 months of azathioprine that the other group got. The interesting thing about the study is it shows us a little bit about which patients are likely to relapse. And it turns out that patients who have B-cell depletion and remain ANCA negative almost never relapse. And in fact, in this study, only 4 of those patients relapsed out of the 197 that were enrolled. That probably shows us a little bit more about the importance of B-cells to the pathogenesis of this diagnosis. So to sum up, rituximab is non-inferior to cyclophosphamide for remission induction in patients with severe ANCA-associated vasculitis. Although I didn't show you these data, if you look at specifically at the patients who had bad kidney involvement or bad lung involvement, rituximab also seems to be equally effective as cyclophosphamide for the treatment of those particular patients. Treatment with rituximab is superior to cyclophosphamide for patients who specifically had a history of relapsing disease, which again indicates which patients probably should be treated with rituximab up front. And finally, when you look at remission rates at 18 months, those 4 doses of rituximab held patients just as well as the 6 months of cyclophosphamide and the 12 months of azathioprine. The reason why that's an important observation is you got to think about the cost. So the patients who got treated with rituximab do have a large upfront cost. Rituximab is not cheap. But then the patients who get treated with cyclophosphamide have to take cyclophosphamide for 6 months. That's a monthly copay. They have to take azathioprine for 12 months. That's another monthly copay. And then there's all the monitoring that's associated with these drugs. Because patients who get treated with cyclophosphamide, they get weekly CBCs from me. When they go over to azathioprine, they get monthly CBCs. When you're treating with azathioprine, you have to check a thiopurine methyltransferase level to make sure that the patient can tolerate that drug. That's an expensive test that gets sent off to California for 2 weeks, God knows why. When the patients are treated with other drugs, there's other testing and other monitoring that has to take place, so switching from azathioprine to another agent doesn't help. Finally, there are all the complications of these diagnoses that need to be monitored on a regular basis. The risk of bladder cancer, hemorrhagic cystitis, lymphoma, all these things are things I have to look for in my patients on a periodic basis that don't occur with the rituximab group. So to sum up, remember, so if this is vasculitis, and this is cyclophosphamide, cyclophosphamide definitely works. Cyclophosphamide is not going anywhere for the treatment of ANCA-associated vasculitis. But it's such an aggressive agent that you have to think about the cost. So that's the reason why rituximab is such an interesting alternative, because rituximab is a very directed, very specific therapy that seems to get us to exactly where we need to go with a lot less damage. And that's all I had. Thank you very much.
So I'm sorry that I missed the beginning of this. I had to go to the other side. But did you try anybody on our high-dose cyclophosphamide regimen rather than a 6-month regimen?
Yeah, that's a great question. And the answer is the vasculitis group was never able to enroll anyone into Dr. Brodsky's protocol using high-dose cyclophosphamide. And it was predominantly luck of the draw. Michelle Petrie managed to get more patients into that study. And then when the results seemed to indicate that patients with lupus relapsed, even after being treated with high-dose cyclophosphamide, we lost interest. It's not to say that it wouldn't be effective, though, and it might actually expose patients to even less cyclophosphamide than our current regimen. And I think I'm being encouraged to leave the stage, so thank you very much. No. Sorry, I got one more question. Yes.
Was there any difference in the patients who had MPO versus PR3 antibodies?
Yeah, so the question is there any difference between the patients who have MPO versus PR3 antibodies? And for those of you who don't do this for a living like we do, ANCA antibodies come in 2 different flavors, an antibody against proteinase 3 and an antibody against myeloperoxidase. It's the anti-PR3 patients that end up being the most severe patients. They have bad disease. They're the more likely to have glomerulonephritis. They're more likely to relapse. And the MPO patients are less likely to do those things. They're more likely to have a monophasic illness. They're less likely to have severe kidney involvement. They have an improved mortality. In the RAVE trial, it seems like that the difference between PR3 patients and MPO patients is just that, regardless of whether they got treated with rituximab versus cyclophosphamide. The PR3 patients were no more or less likely to respond to rituximab than the MPO patients.
Can I ask you a question?
Sure.
For those patients you treated for relapse, did you retreat them?
Yeah, so that's a great question. So,
How often you can retreat them?
yeah, that's an unfortunate question. Because the question is about patients who relapse. Did we retreat them with rituximab, and if so, how often did we retreat them with rituximab? And at that point, evidence-based medicine is sort of in my rearview mirror, because the problem with this drug is this manuscript was published in 2010, which means that we don't actually have a large experience with patients who've received multiple courses of rituximab. What I will say is that clinically, we have a number of patients who we've retreated with rituximab several times, and it seems to be very effective at maintaining remission. The question is whether or not they will continue to be effective in maintaining remission in patients who get treated, say, for 5, 6, 7 years in a row, and that question I can't answer. The longest patients have been treated with rituximab for ANCA-associated vasculitis is maybe 5 years. And for those 5 years, those are 5 pretty good years. I'm not sure what the 6th year is going to look like, though. Oh, oh.
I'm sorry, we have to push on.
Thank you.
Thank you very much. It's quite an entertaining talk. So we have a last speaker in front of us, Dr. Zuhan Lee, who is the assistant professor of medicine, and he finished his PhD in the University of Maryland, and then went to the fellowship to the NIH and to Johns Hopkins, and he will tell us about autoimmunity in the gut.
First of all, I want to thank Dr. Rose for the invitation to this great seminar, really great symposium. I also want to thank you promoted me to full professor in this one day. So I didn't notice actually the list as a full professor. I am not a full professor. I'm too young to be a full professor. So anyway, thanks for all stay this late. This is a problem in the map.
There we go.
Okay, there we go.
I think I know what's wrong. You're running way higher than our scan rate. See?
Let me play the work okay probably. There.
See?
Thank you. Thanks again for staying until the end. Since we have already have two great talk, and then actually by Bill and VJ, like those are two giants in this field. So if you see my result, my things different from theirs, go with theirs. Okay, they're the giant. So I'm gonna focus on more specific diseases like what we have studied, IBD. Since some of the audience actually in my talk before, so but some not. I'm gonna give a quick. This is what I'm gonna talk about. Actually, I changed a little bit after listen to the previous talk. So basically, I'm gonna tell you about the quick background, and then we'll also discuss about the genetic part of IBD, and then this has been exploding in the last few years. And then we'll show you that the multiple cytokine that's always related pathway that's involving the pathogenesis of IBD. I'm going to talk about some key cytokines that are used for therapy. And then we are still not there yet, but actually we right now clinically we're doing pretty well. I'm going to have a quick summary. And then, first of all, inflammatory bowel disease. Oh, sorry. This is we call IBD, right? Don't confuse this with IBS because they're totally different disease. Because the irritable bowel syndrome, a lot of people get confused. They always ask me, like, they're totally different. So this is a disease, it's incurable, chronic, very often debilitating to a lot of patients. It has two main subtypes. One is called Crohn's disease or called CD. So if you have this disease, the disease can occur in any part of the GI tract. Sometimes some people have more part than others, but most often in the ileocecum conjunction area here, or in the colon. That's most common one. And then the other called ulcerative colitis. This we call UC. This exclusively occur in colon. There are about 1.4 million North Americans have IBD. So I can just show you quickly the disease plan. If you are healthy, you have a healthy gut. When you look at it with the endoscopy, from inside the GI tract, this is what it looks like. It's very nice, smooth, beautiful GI surface, luminal surface. When you have a mild UC, this is what it looks like. It's like bumpy. This is called mild, but actually it's painful. Usually all patients who have IBD, they will have either a diarrhea, abdominal pain, and then if you have a CD, you see you have this ulcer, and then these can be penetrating. Actually, and then there's other forms that actually can be what we call the extraintestinal manifestation. That can occur to any part of the major body part, like skin, joints, liver. So those actually relatively rare, but it's happened in many patients. There are also a complication. This is actually the worst form of the Crohn, usually occurring Crohn's. Most common example are those. I think this is a lot better. This what we call perianal fistula. So you can see, but just by the meaning of the word, you see there's formed these channels. Actually, fecal matter will leak from here. So actually, patient who has to have to wear diapers because you have no control over the. You can only control the fecal thing from here, not here, right? And then this can occur in any part of the organ that is adjacent to the colon. For example, here, this is the female organ, this is the vagina, right? So this is the colon, this is colon area, rectum. You can see it has fused a channel, so the fecal matter goes to the vagina. So that's why this disease is a really horrible disease if you have this. Most of the patients will have surgery, but fortunately, there are new biological drug that now actually quite effective to reverse this process if it's not too severe. And then another major complication is the stricturing. Actually, at Hopkins, our GI surgery, IBD-related GI surgery, about 70%, because we are getting the patient. About 70% of all patients of IBD-related surgery actually are due to stricturing because there are no very good effective medication to this kind of complication. Pathogenesis, I mean, this is as a study, this IBD has been really, there's so much effort in the last many years, but we still know quite little. We still don't know exactly what's going on, but what we do know is it's involving genetics. The environmental has a lot of effect. I want to mention that you can see this. Some are positive, some are negative, and then those things interacting to make your immune system that overreacting, so you have an inflammatory bowel disease. When you have a gene, now you're going to have a disease. So I'm going to mention some little more soon. So let's just start. What do we think how this disease was developed? In our GI tract, right? You all know this is like a really hot area right now. The what we call the microbiota in the GI tract. There's more bacteria number in terms of number of cell in our GI tract than our whole cell body of cell in numbers, several-fold more. So what they do is this is real lumen, this is epithelial, like a colonic or intestinal epithelial cells. So you're fusing a lot of bacteria. There's an interacting all the time. And through evolution, they probably have a harmony somehow. But when something triggered, something not right, what happens is that your immune system overreact. You heard the talk in the morning and afternoon, including Jay talk about IL-10, which also I'm going to mention about. So you have immunity start response like a macrophage and a neutrophil, and then your adaptive immune system start. So if I enlarge this, you see this several times today. So I make a very simple form. Actually, we have this four major pathway. I'm not talking about some minor ones. So Th1, Th17, those three are actually what we call bad in our IBD term actually. And then the Treg, of course, suppressing. And then they actually have a plasticity that they can actually converting somehow. But I put a very simple form. Okay, don't get me wrong. So because there are a lot of other diseases each pathway can lead to, I just make it very simple. So CD in general, again I say in general, right? It's not like there are some overlapping thing. In general, CD is a disease of a Th1 or Th17 dominant. UC is the Th2 dominant. So you will see all this. The reason I use the cytokine network is my network is much simpler. We just talk about cytokine. You hear Regis talk, there's like even more, right? A lot of more genes involved. So all these cytokine, I mean, if you can find that one that is key, very important one, if you shut down that one, you could actually prevent disease, or at least maybe therapeutic to the disease. That's actually what people are based on for design biological therapy, so which I'll mention a little bit. First, the genetics, right? So I'm going to quickly show. This you see the CD. This lasts like 10 years or 12 years. There's a dramatic development in this gene sequencing, then identify IBD's risk genes or risk locus. So we have now more than 100 locus for Crohn's, risk locus, and then about 70 for UC. But I told you, I warn you that those are very low penetrating genes. I mean, they vary from like less than 1.5 fold to like a few fold. If you have the gene, your risk will be only very little, very low penetrating. So those genes actually overlapping. If you look at this here, some of the Crohn's specific, some are UC specific, and then some actually both. So because this topic is cytokine, right? So if you just go look at the cytokine, in each section, you see cytokine. Those are mutation or SNP, what we call polymorphism. So those are direct mutation that has a risk for IBD. So you can see in all three forms. If I put another kind of a contact, instead of looking at individual cytokine, if you put all this gene into a pathway, you summarize about 5 pathways involving IBD. You know, all of these 5, only this number 4, defective barrier function, that have less direct link to cytokine information. All the other 4 actually all related to cytokine. Now 2 as this kind of sensor that lead to interleukin-1 beta increase. This is one of the key things I will show you. We have some data that if you block this, actually you can really have some therapeutic benefit. And then ATG16, this is the autophagy one. I'm going to show you next slide that the lot of gene, that the cytokine was deeply involved. IL-10 signaling, we're going to talk a little bit. And then IL-23, this is Th17 red. See, they're all related to cytokine or chemokine. Well, I told you autophagy, because ATG16 gene is one of the autophagy gene, right? Autophagy actually, there are cytokine that influence it, and then there's cytokine that being influenced by it. So then you have other cytokine either that play a negative regulation on autophagy. So everything is around cytokine. This is also another great benefit in the recent year because the genome-wide, what we call GWAS, sequence for genes. So we do IBD because we are IBD people, right? And then there are other people do other different immune disease. Turns out when put data together, there are lots of overlapping between the autoimmune disease. I just mentioned some, like multiple sclerosis, like primary biliary cirrhosis, like systemic lupus, psoriasis, asthma, type 1, type 2 diabetes, celiac disease. You see, all these, they all share that a common thing. What this tells us is that there's a common, even though the presentation are different organ or tissue, phenotypically they are quite different disease, but there are some fundamental similarity in terms of disease pathogenesis. I'll give you, those I mentioned to you, those are the genes with low penetration, but they're also rare, but really, really deep penetration. If you have a mutation, for example, IL-10, this was published 2009. This caused a big stir because for a long time people think we have IL-10 mice, knockout mice. People think, oh, there's no human disease about IL-10. So this is the one actually show that they found this patient that have Crohn-like disease very early, like a few months to less than a year. And then they sequence the gene. They actually, this is called I think they make a linkage analysis. They found this gene is IL-10 receptor 2, which is truncated. They have non-functional IL-10 receptor. As a result, they have this really, really bad Crohn's disease. They have like, see the dermatitis, they have like a mini fistula, and they look at this perianal fistula. It's really, really bad. So they also have siblings who are normal. They don't have this gene mutation. So what they did a bone marrow transplant, completely cured this patient. So this is the one of the very good example. This is 100% penetrate. If you have this gene, you are bound to have disease. So we did some. Now we all try to know what cytokine really involved this disease, right? So for us doing research, so we use human, we use animal models. So one of the animal models that we're using is DSS colitis versus TNBS colitis. So you can just do a simply serum level profiling of the cytokine. You are able to, using the cytokine profile, to differentiate those different types. Like this is normal, each ball is a mice. If they're, you see this is the TNBS chronic colitis mimic Crohn's disease. Or UC, like this, or mimic UC, chronic UC, this is the chronic DSS model. You can see, just use the cytokine, you can separate very well. So that's lead to us that using this as a biomarker. So we patent this for, like, we have human data as well. I'll show you. So we also did a lot of analysis from both tissues and the serum of the patient for other cytokine. This is a summary of our data and then all the other data published. So in Crohn's disease, those are the cytokines that's upregulated. So here in UC, you have those cytokines. You can look at only the red actually redundant. They're the same. All the others are quite different. So you can just by looking at the cytokine, there's different diseases. That gives us a way that using this, design the algorithm using this cytokine used as a biomarker, discovery, using cytokine as a biomarker. And then we just did a serum level cytokine using multiplex. So you can identify those, and then you can really just use a serum cytokine. See, each ball is a human being. So red is Crohn, blue is UC, green is normal, healthy. You can see how well they are clustered. And then even there's a patient, if they're, you see this was misclassified here. We don't know whether this patient was misclassified or like somehow you can tell if they're, just use cytokine. So cytokine difference you can make a diagnosis for a disease, meaning that some of these cytokine, if you block them, you might have therapeutic effects. That's what everybody was looking for. I'll give you an example we did in the animal model. We have this IBD model, right? TNBS and DSS model. If we treat the DSS colitis, actually just using cytokine, you can see that there's pattern shift close to the normal, but it never reaches the normal. It never mingle. It always like somewhere close. But this is what we call a UC-like disease. If you use another drug to treat a Crohn-like disease, you see they're also closer. But they never meet. These two groups never meet, and they never meet the control. Meaning that's why this IBD is incurable. I mean, you can make it better, but you never make it like normal. So at least so far with the therapeutic. So in human, this is the thing that we show over and over. In human clinical trial, one of the most successful, that's not only IBD, also other autoimmune disease, is this anti-TNF therapy. You all know, biologic. There are so many different forms. Remicade and infliximab is the early form. They're still used. Here we have 2 infusion centers. Patients have to come in to the infusion. It works very well. But of course, there's about 50% or 30% patients do not respond. But for those who respond, this basically revolutionized the entire IBD therapy, and so as RA and psoriasis. So that's one of the most successful story. And then there's another one ongoing. So we're GI division of IBD, we also have a clinical trial just approved. We have the ongoing. So anti-top P40 therapy. So the beauty of this therapy, this drug called ustekinumab. I mean, some of you may heard. So this actually requires for both T12 and T17. You basically you hit one thing for like one stone kill 2 birds. So you try to block both pathways. This is the clinical 3 trial I think phase 3 now. For what I know, it's working very well. So here's a list of the other ongoing. I mean, all the drug companies right now are focused on this biological therapy. I told you these 2 that work the best. I think these are going to be definitely okay. So far, I think they're going to be okay. And then all these others, some are receptors or some are cytokine. Some are antibody. Like if it's a bad cytokine, you use the antibody to neutralize it. Some are good cytokine. For example, IL-10, IL-11. And then I actually asked Jay a question about the therapy in the human. It's not working very well. You see the one in red, that's all failed. So I think I can predict that most of this will fail. There will probably only 1 or 2 that will survive, and then it turned out it's good. I can tell you, like our 6 receptor right now in phase 2, from our animal experiment, this will fail for sure. Because we think when we make this happen, actually it makes disease worse. But anyway, so now how do we make the biological therapy more effective? So the key is to identify right cytokine to interfere with, right? So using human is very difficult. You can't, when people come to us, they already have a disease. So if you can identify the early stage of the disease, what has been changing, that's probably the target you should hit. So we use this alkaline mice that Jay used the same thing. So the alcohol, we keep them in a Helicobacter pylori room. They have, in our Hopkins facility, 1 month, those mice have no disease, even macroscopic disease. But after 3 months, you have probably 40-something% of mice have macroscopic disease. But some still have no macroscopic disease. You can see here, this is the colon, right? It's very similar. But if you look carefully, some of them already have microscopic disease, but not the macroscopic. Macroscopic means you can see by your eye. So then we'll look what happened, what the cytokine expression on the different stages and see what come earliest. What are the earliest cytokine that change? As I said, you use different models. You can see multiple cytokine was increased. You can see many cytokine was increased, either IL-10 knockout or DSS. These are when they have already macroscopic disease, the disease you can see. And then we extract the colonic mucosal, and then did a multiplex analysis of the mucosal extract. And then look for earliest to compare 1 month and the 3 month, wild type and IL-10. What you can see is that in some cytokine, you only see big increase when they have disease. You see, I list a few here. This is not all. This will only show a few for you. You see, you don't see it when they were really young without any disease. But then there are some cytokine, even 1 month, you start to see there. Even though at that point there's no disease at all, but cytokine, biochemically, they already have disease. So this is the power of biochemistry. This is the probably the way that we identify this. So see, I can tell you one of them is TNF-alpha. This is the one that works the best. Even though we still don't understand why TNF-alpha works so well, because if you look at the human, we did a lot of human cytokine profiling from the blood. Actually, they're very low. Probably half of them is undetectable, or it's right at the detection limit. So I can't trust the data. We still don't know why TNF-alpha work, but maybe when they're very low, they already actually play a very important role. So that's why TNF-alpha works so well. So you can see those can all be a good target. Autoimmunity is another one that I just told you work very well. You see, we identified this early one. 2 of them are among those that work the best right now. So I think you can only do this in human. I'll give you another example. This is what's going on in our lab. Because we use multiple models. So I'll tell you a little bit of IL-22 story. IL-22 is considered an IL-10 family. If you're IL-10 family, you know there might be something good about it, right? Because we know IL-10 is good. But not necessarily all of them are the case. But at least we know in the gut information field or the IBD field, actually, there are a lot of data. Most data will support that this cytokine has a anti-inflammatory function. So there are several papers published that if you increase this locally, or even not locally, actually, you make the disease better so that it's like a therapeutic. But also there are some other data that say the opposite, but fewer publication. So it's a strong activator of STAT3. So remember STAT3 you heard about from Bill and Vijay, all the other people that before me that talk about it. Those are the STAT3 in the T cell. I'm talking about here in colonic epithelial, IL-22 receptor is not expressed in any of the T cell. It is expressed in the colonic epithelial cell. So the target is very specific. So when in the colonic epithelial cell, when you have a STAT3 activation, actually it's protective. So that's the key thing. So don't get confused with because there's this very cell-specific kind of action. So based on our previous study, we think IL-22 will be protective. So you overexpress your transgenic, let's make the mouse produce more IL-22. We're predicting that going to be better. Turns out, when then we cross this transgenic IL-22 mouse with IL-10, turns out actually the disease is getting worse. So it's totally opposite of what we're thinking. So why is that? So I just show you like wild type. This is the there's the creep. This is the proximal colon. You can see this. There's the goblet cell, the white goblet cell. When you have a disease, usually typical IL-10 colitis is they have a hypertrophy, like the overgrowth, like they're much bigger. You see the same magnification. You cannot see this thing doesn't work. You cannot see the whole creep anymore because they're so big, so overgrowth. So, and then you have a lot of infiltration. So it's, instead of protective, actually it's getting the disease worse. So just to summarize what's going on is that turns out if you have we have actually transgenic with high level of IL-22 or low level IL-22. So in either case, you see active phospholipid. This is the colonic mucosal extract that we do the Western blot now. You see the phospholipid 3 was increased. That means activated. When you doesn't matter low or high. But you see that this is the pathway that is supposed to be protective. But unfortunately, you also see another thing get activated with a high level of IL-22, which is P4442. This MAP kinase pathway activated. People think if this one gets activated, actually it'll play a pro-inflammatory. So we think this is what happens is like when you have increased IL-22, if you increase to a right concentration, it may be protective. But if we don't know what concentration is good, really. But there's the balance between this pathway. Again, this is not a big thing. So this is a hypothesis, right? Because we just based on our data and based also other published data. So you have this balance, right? If you can manipulate this well enough, then it's protective. But if you get this guy also going up, then the balance gets screwed up. Then you will still have inflammation, which is mild though. Then in some other condition, if you cross with IL-10, now you already have IL-10 knockout itself has a problem. Then what happens is that you have many other cytokines add to this group. So this whole balance will tip over more there. Then you get a more severe disease. That's what we did is we used multiplex cytokine most people will analyze the cytokine, use the multiplex for the serum level or tissue culture. Right? We did the tissue chronic mucosal extract. So you can also do this just by very simple PCR, as what we did. Remember I showed you that we have IL-10 mice that's 3 months old. Some has disease, macroscopic disease, some don't. You see, those are hazards. See, all the PCR, all this cytokine that's high. That for this, we don't see any sign of a macroscopic disease. You see this cytokine already start very high. So what they are, if you look at them again, you see you have TNF-alpha in that list. I know there's clinical trial or a lot of companies try to do the Th17. We don't know how good this will do. Theoretically, it should work because it comes up all the time when we do this screening. Last example that the work done in our lab, so this was actually going to be published soon, is we did, it's cytokine increased, but the trigger, the upstream may be something else. So we did the simple screen. Just as I said, we can use many kind of way of screen early, what happened in the early time, even before disease was onset. So what we did, this is repeat. This is two actually duplicate experiment with two different mice, with 2 months, 1 month, 2 months, 3 months, wild type, IL-10 knockout mice without macroscopic disease, 1 to 3 months, and then those with 1 to 3, 2 months, 3 months. Because then what we found is, see this protein, you guys know this NOP3. This is actually one of the nuclear NOD2 containing leucine repeat protein that actually involves sensing the bacteria. There's a huge family in there. So this was, you see, it's upregulated even when they're 1 month, nothing happened. It's upregulated. This is apple number 1, 2, 3 is in the order of which one started getting activated. See this number 1, this guy here, and then number 2 is R1 beta, which is downstream of NOP3. So NOP2 is the last. You see, only when they have disease, NOP2 start getting upregulated. I want to mention to you is NOP2 is the gene, is the one of the best known genes. It's the poster boy for IBD people, because this is the first gene get identified in IBD that linked to has a risk for IBD, and it has the highest penetration. If you have homozygous, twin, if you have a NOP2, then you have your chance of having the disease, I think it's 12 times or something. It's still not that high, but this is the highest one. This is the highest penetrating mutation. But it activated the last. So based on what we have, I have this model. So due to that bacteria, somehow your communication, your gut bacteria and your gut mucosa are communicating, something go weird. So then your system sensing this bacteria, then you activate the NOP2 inflammasome. That's what we call. What happens is that the inflammasome, when they're activated, what they do is they cleave the existing caspase 1 and they make it active. So what caspase 1 did is they're going to cleave the pro-interleukin 1 beta and then activate the interleukin 1 beta. So make this guy activate. So based on our Western, I just show you the sequence of which one will activate first. So then that leads to probably further down the NOP2 activation. We know NOP2 is the gene that's linked to IBD. So probably lead to a lot of other cytokine activation. Of course, some NOP2 itself can sense the bacteria from outside. But this NOP2 is an intracellular receptor for some of the bacterial surface component. So when this happens, then you have a massive secretion of lot of other cytokine leading to inflammation and colitis. So the key here, if you give IL-10, then you block the whole thing. Very early stage, right? But we know the IL-10 right now clinical trial doesn't work. That's something we're not going to think of, but at least in theory it should work. What do we think is, what if we find something that can block this thing? Drug. Glabiride is the one that we tried by searching literature. So actually, this is the drug used for type 1 diabetes, I think. But actually, it's not necessarily very specific to NOP3 activation, but it can block this. So I told the postdoc, let's try and on the mice and see what happened. Turns out it worked pretty well. So we stopped the whole thing. It's a very early stage. So that's really have therapeutic benefit. So you can see after you treat them, all this major bad cytokine get reduced. I want to have this final slide that shows that, as a summary perspective. So there's very complicated. I mean, it's more complicated. This is only a few that I put in there. So the key problem in the therapeutical field, like for pharmaceutical companies, that they need a good target, because develop every drug is so expensive. You have now all these major companies have up to 10 biologic drug in the pipeline, but they are hoping one of them is going to work. Then they'll make their living. So that's what for all us, at least in terms of IBD, that's what we should looking for the early event that can be the best target for therapeutic intervention. With that, I want to acknowledge the people involved. So I have a lot of collaborators clinically getting samples, and then I have from surgery, and then actually Dr. Rose group people involved in us, doing serum biomarkers, and then my collaborator in NIH doing transgenic. Those are the people at a different time in my lab, and then those are the people involved in the data that I present to you. May, who is in the audience, Philip, Lin, he just went back to China, and then Linda, who went back to Netherlands. And this is the funding source. Thanks for your attention. I will be happy to entertain any questions. Yeah, Jay.
Thank you. I'm curious, in your IL-10 knockout experiments, do you see, or maybe you showed those data, do you see an upregulation of IL-22 in the mucosa in the absence of IL-10?
Let me think. IL-22. I don't remember. If it is, it's not a major one. I'll look at it. I'll let you know. I can't tell you something if I'm not quite sure. So I think at least not very predominant, because otherwise I will remember. Because we did 24 cytokine profiling.
Right.
Yeah. Yes.
On your experiment on the IL-22 transgenic, is it possible that having sustained IL-22 leads to downregulation of the IL-22 receptor on the clonic epithelium, and maybe there's no longer the protective effects of IL-22?
I think it's upregulated. The
receptor is upregulated?
If you have increased, sustained chronic high level of IL-22, I think.
Thank you very much.
Okay, thanks for being late.